our beloved coordinator, Dr. Jay Shah, respected faculties, Dr. Atul Abhyankar and Dr. Kamal Sharma, our panel members, Dr. Karthik Bhosle. A warm welcome on behalf of Agam Life Sciences to our webinar highlighting the best of 75th Conference of Cardiology Society of India. As we are convened to explore the latest advancements, breakthroughs, and insights in the realm of cardiology, let us collectively celebrate the achievements that have shaped in the past and will undoubtedly influence the future of cardiovascular care. Thank you very much for joining us on this journey of knowledge and innovation. Let us commence the exploration of the finest aspects of 75th CSI Conference in Cardiology. I wish all of you will enjoy this webinar. It's over to you, Dr. Jayasha.
Thank you, Sapanvi. Good evening, all respected faculties and all esteemed colleagues. So, without wasting much of the time, let me invite Dr. Atul sir. Atul Abhyankar sir doesn't require any introduction. He's a very renowned cardiologist of global, category. He's basically a director and a chief interventional cardiologist at Mahavir Institute at Mahavir Heart Institute at Surat, and he has, he has been a senior faculty and course director of many cardiology workshop, and he is truly a treat to watch him and to deliver a talk regarding the heart failure. And the second one is the textbook himself. He is Dr. Kamal Sharma. He is a very senior cardiologist and a very good friend. He's a chief intervention cardiologist of Sal Hospital, Ahmedabad, and it's always been a treat to watch him, delivering a talk. Especially the talk which has been given to him is regarding the lipids, basics, and beyond. So over to Atul sir and Kamal bhai. The first talk probably would be with Atul sir. Atul sir is going to speak about the role of anti-failure strategy and the role of anti-failure pillar therapies for the patients having heart failure with reduced ejection fraction. Over to Atul sir.
Thank you, Jai, and just share my screen. Slides visible?
Yes, sir.
So thanks for this opportunity to give an overview. I mean, it's a topic on which a whole seminar or conferences are held, but I'm going to give you in 10 minutes a brief overview of the current concepts, or in general, what is the present status about managing heart failure. So we know that the InterHeart study showed that the cardiovascular risk factors like obesity, hypertension, and diabetes are very high among Indian population, starting at a very young age, and as compared to the Western population. We don't know why all these factors are there. They are poorly investigated. Let's look at how serious is the problem of heart failure. So if you look at the mortality risk, so mortality risks remain urgent and life-threatening. So if you look at the in-hospital mortality, if you look at the 30-day mortality, the 1-year mortality, it's extremely high. And if you look at the 5-year mortality, and as we often quote, that if you look at the 5-year mortality, the 5-year mortality of more than 50% is higher than many of the malignancies. So we generally equate bad prognosis with malignancies, but heart failure even has worse prognosis. Now, one important concept that has evolved, because once we started treating, we came to know about what happens after treatment. And therefore, now we have the 3 ranges of heart failure. That is heart failure with reduced ejection fraction, that is less than 40%. The mid-range ejection fraction, I will talk about the improved ejection fraction later, in the range of 40 to 49%. And you have then a preserved ejection fraction, that is 50% or more. And these are very dynamic categories. That means the patient is not necessarily constantly in one category. but he can progress he can recover and he can become from reduced to mid-range or mid-range to even preserved ejection fraction. And against that, one can go downhill, as would happen in many of the heart failures. And so then the person can go from mid-range to reduced ejection fraction. So various factors like diabetes, ischemic heart disease, higher NT-proBNP at the first time of diagnosis, these are the factors which cause a progression of the disease, that means deterioration, and a relatively younger age, lower severity at the time of diagnosis, shorter duration of heart failure diagnosis, and fewer comorbidities at younger age. These are the factors which help in better recovery. As in any treatment, our goal of treating heart failure is to reduce mortality. Our patient should live longer. We should prevent the recurrent hospitalizations, and we should also improve the quality of life of the patient. So this is basically the aim in any treatment that we use. And probably this is one slide which sums it all in terms of treatment of heart failure. And I think therefore we'll spend a little time on this slide. So needless to say, I don't think that anybody who doesn't know about this, but that we have basically 4 pillars of treatment of heart failure as of now. And there is somebody can say that we have now 5 pillars, but we will, for time being, as per the guideline, we call them 4 pillars, which consists of an ARNI, an SGLT2 inhibitor, a beta blocker, and a mineralocorticoid receptor antagonist or an MRA. So these are the essential components. Apart from this, depending on various situations. So if you have a patient who is congested, who has edema, who is fluid overloaded, then obviously, and for symptomatic relief, we use loop diuretic or thiazide diuretic. For a recently decompensated, now we have a vericiguat, which is a very good molecule. And I'll just briefly mention the end that it's also a good option when you have a CKD up to a certain stage. So that's in that situation. Now, patients who are in atrial fibrillation, you can use digoxin. It's previously, as we know, that digoxin was used probably in treating every heart failure. Now we believe that it's reserved only for those patients who are either refractory to everything else or patients who have atrial fibrillation. If the heart rate, in spite of the beta blocker, remains above 70, then we use ivabradine. For patients who have LBBB in wide QRS, this is kind of too short, but depending on the other criteria related to LBBB, then cardiac resynchronization therapy is required. If ferritin is low, then giving that is also helpful. In fact, it is now required that we should test the ferritin levels in patients with heart failure. In patients, that is in black population, or in patients with renal problems, hydrogen nitrate is an option because some of the other drugs, like especially the ARNI, cannot be given in patients who have higher creatinine. And for patients who have got the mitral regurgitation, functional MR, then we can use devices for mitral closure. Now, what has changed in recent times, which again is not extremely new, but just to mention, that we have moved from what was called as a conventional sequencing. That means what we used to do is start one molecule, wait for some time, see how the patient is doing, then add the other agent, so ACE inhibitor or ARB, beta blocker, then again after some time, see if the patient. So we used to wait for the patient to deteriorate or have more symptoms and then add other agent. That concept is no more true. So now the earlier you start everything better. So the new sequencing is that we start with beta blocker and SGLT2 inhibitor. I don't want to do hair splitting. Some might say in some situation, ARNI is the first choice. But whatever it may be, step 1, step 2 includes all these. The step 3 is MRA. So all these 3 steps should be achieved within 4 weeks, if not possible to start simultaneously. So this should be started within as short a period as possible. Now, what is the effect of the treatment modalities? Now, the standard pillars, as you can see here at the top, that when you combine these drugs, out of all possible combinations of 2, 3, or 4 drugs, the best possible combination which causes 64% reduction in cardiovascular mortality and hospitalization for heart failure, is a combination that involves all four pillars. And the SGLT2 is a very important integral part of these combination, which significantly reduces the heart endpoints. So this is just to mention because we always love to quote guidelines. So this is a class 1A indication that for SGLT2 inhibitors for reduced ejection fraction, and I will be coming to the mid-range and in the subsequent part. So let me not just spend time on this. So these are the trials, and I am going to talk a little detail about this in the subsequent slide. So about ARNI again, this is nothing new. We know that ARNI is a class 1 indication in patients with heart failure in class 2 to 3 symptoms. Now, what I would like to sort of emphasize in this is the initiation at early phase. That means even in patients who are in hospital and they have been stabilized, they are off inotropes, they are not on increasing diuretic dose, these patients should be initiated on ARNI, whatever best possible combination in hospital. So you don't actually wait till the patient is discharged and comes back for its first follow-up and then decide to start ARNI. So except for those situations where you have problem with low blood pressure, etc., it is now a concept to start practically applicable to every drug, but ARNI, which people were concerned about. So if the blood pressure permits, then ARNI should be started. We have a huge amount of evidence starting from Paradigm F, Paragon HF, and other trials where we know. Now, comparatively, beta blocker, there is no recent sort of trial, but we have had plenty of evidences of beta blocker in heart failure. So we have trials with various agents. So we have bisoprolol, carvedilol, metoprolol, nebivolol, etc. But probably it is all right to choose either a carvedilol, which probably has relatively more data about it, but there is nothing wrong if you choose metoprolol instead of carvedilol or even bisoprolol. And bisoprolol might be a good choice in patients who have relatively higher heart rates. So any of these beta blockers suitable, and they are all in guidelines. So this is again class 1A indication. So I have already said that all of these are essential. MRAs, very important to remember that these are often forgotten by physicians or even by cardiologists sometimes, that you add everything else, but you do not start the mineralocorticoid receptor antagonists, which are very essential. So what is important in this is that they can be started in patients who have slightly hypotension also, because they don't have much effect on the blood pressure lowering. You must first check creatinine and potassium when we are doing that. Now, traditionally, we have been using spironolactone, which has been used for years, but there is a problem in terms of the gynecomastia. So there is also an evidence that eplerenone in many ways is superior. There's a lesser sexual side effects, no gynecomastia. So we can choose eplerenone, and this is again to emphasize that one must specifically keep in mind that MRA and eplerenone should be started. Now, in both, whatever you choose, we must look at creatinine and not give it when the creatinine is elevated about 2.5. Hyperkalemia incidence again is lower with eplerenone as compared to spironolactone, but you have to reduce or adjust the dose or even stop it temporarily if the potassium is elevated, which is very important. Now, coming to the subsequent part, and that is the change in terms of the types of heart failure that is happening. If you look at the decade of 85 to 94 versus that of 5 to 14, then you will find that the proportion of heart failure with preserved ejection fraction has gone up and the reduced ejection fraction has gone down, and the mid-range somewhere stays in the same zone. So why is this happening? Is probably the first and foremost reason is that we now have better recognition of this phenomena of preserved heart failure with preserved ejection fraction. We have better diagnostic techniques. We commonly employ doing tests like NT-proBNP. Also, because as we have more aging population and populations with more comorbidities that are associated with aging, and therefore the incidence of heart failure with preserved ejection fraction is increasing with time. Now, if you look at this mid-range or preserved ejection fraction, again, the definitions are not watertight compartments. You have to understand conceptually that this is just, which is not reduced, it was called preserved. Now we have mid-range, and the one that is above 50 is preserved. So the definition sort of somewhat keeps changing. So these are the previous trials, which unfortunately in those patients who had relatively preserved ejection fraction did not show much benefit. And so we could use only agents for symptomatic relief like diuretics and to some extent MRAs, but no real hard point benefit was achieved in patients with preserved ejection fraction. But now we have at least one option, and that is dapagliflozin, and this is the outcome which shows that there is a 18% relative risk reduction in terms of the combined endpoints of cardiovascular mortality, hospitalization for heart failure, urgent heart failure visits. So this benefit starts pretty early, and there is a good 18% risk reduction, and which is statistically significant, and NNT is also very low. Now, what is most important is that these drugs like DAPA or EMPA are useful in heart failure, irrespective of the patient, whether the patient is diabetic or not. So that's again very well established fact. Now, coming to this ejection fraction category, the preserved ejection fraction, the truly preserved ejection fraction category has kind of diverse etiologies, and therefore it's been very difficult to find a drug which kind of helps in reducing mortality. But if you look at the outcome of the DELIVER trial, then you will find that in those which we call normal or supernormal ejection fraction, that is more than 60%, even in those patients, there was a benefit. So this is the first time that we have something which reduces hard endpoint. Second, those with improved, that means those who started with less than 40% and those who have improved, there also it was very effective. Now, slight difference between the supernormal ejection fraction, that although DAPA showed the benefit in them, but EMPA did not. Again, I think that this is somewhat of a situation where probably we might in future explore more data and find that actually it is a class effect rather than a specific drug effect. Coming to the next question, as we said, that LVEF is dynamic. And so what happens when the ejection fraction improves? It improves considerably, and whether we stop the medication or we continue with the medication. So the guidelines clearly suggest that in those patients with improved ejection fraction after treatment, the GDMT should be continued to prevent the relapse of heart failure and LV dysfunction, even in those patients who may become asymptomatic. So secondly, we also have data, again, in the limited time, I can't give you all the data, but we have data that in this category of improved ejection fraction, at least SGLT2 and to a large extent ARNI shows that the benefit will continue and you should continue the medications. So thank you. I tried to sort of cover in a brief overview whatever best I could in this much time. Just to say that now we have a new option of Varisigvert, which can be used in worsening heart failure, and even in those patients who have other limitations because of either symptomatic hypertension or because of elevated creatinine, where we can't use ARNI or sometimes even DAP. So thank you.
Thank you, sir. It was a very lucid talk regarding all the phases of heart failure, right from reduced ejection fraction to improved ejection fraction heart failure. So with that, I would like to invite the three of our esteemed panelists, Dr. Dinesh Raj, who is a senior cardiologist from Rajkot, Dr. Karthik Bosle, who is joined from Pune. He is a chief interventional cardiologist from Jupiter Hospital, and a dear friend, Dr. Sandar Patel, who is again a cardiologist, senior interventional cardiologist from Jivraj Mehta Hospital. So just Sapan bhai, if I can ask, are we going to do the discussion right now or after the talk of Dr. Kamal bhai?
You're muted.
Sapan, you're muted.
Dr. Jay, I
I
unfortunately
think
Yes, yes,
I
yeah.
yes.
have.
My speaker was muted. Sir, let us finish first Dr. Kamal Sharma's speech.
Okay.
Yeah, sorry, Dr. Jay, I
Yes, sir.
unfortunately have some other very pressing commitment. And so
Okay.
if there is any one or two sort of these things that you somebody wants to ask, then otherwise I will have to then leave.
Yeah, I understand, sir. No problem, sir. So, sir, just for the sake of initiating one talk, how would you manage, sir, heart failure patient, especially those who are coming with low EGFR?
Yeah, I mean, I already mentioned in the talk that the traditional options were, of course, that those who cannot take those out of those fillers, things like DAPA and ARNI, I mean, HLT2 and ARNI, then hydrolysine ISDN combination is one of the options for them. Well, the newer option, of course, that you can use Vericiguat, except for those patients who have frank CKD. I mean, those who are on like dialyzed patients. But otherwise, with pretty low EGFR, one we have used Vericiguat very effectively for those patients who, except for beta blockers, probably can't get nothing for treating heart failure. So these are the options, and as the situation evolves, if the creatinine improves, and then you can, of course, attempt to start HLD2 and ARNI.
So, I think very well, explained, sir. Especially those who are having low EGFR, the idea is to not further deterioration of renal functionality. And in that case, I think I would say that the SGLT2 inhibitor would score over RNI. And according to the hemodynamic parameter and the volume status of the patient, you can always titrate the anti-failure therapy. So with that, I would like to ask either Dr. Sandar, Dr. Karthik, or Dr. Dinesh Raj, who can have some quick questions or any suggestion or comment for Atul sir, so that we can proceed further. Dr. Sandar, are you there? Maybe Dr.
Hello.
Karthik.
Yes,
Dr. Karthik is there.
Karthik is
Yeah.
there. Yeah, yeah. Yes, yes. I just want to ask like one question, especially like in case of heart failure with reduced ejection fraction, who are very severely reduced, like you have 20% and 15%. In that case, like how this RNA, because whenever we start, they go in hypotension because their baseline blood pressure is only 90, 94. Like how should we go with them, especially for the ARNI? And second question is like I want to ask about if there is a very low EF and there is a tachycardia, does the digoxin fit somewhere for the contractility and rate as well?
If it is, I will ask this, answer the second part first. That is, if you have ivabradine is very useful, of course, apart from increasing the dose of beta blocker to whatever optimal level, provided the patient is in sinus rhythm. If he is in atrial fibrillation, then obviously digoxin remains the only option. Digoxin can be used as a desperate measure subsequently. I mean, it is not an absolute contraindication, but digoxin is not now a drug at the forefront. So we use it when you have a desperate situation. And that's even with sinus rhythm, it is not a contraindication, but that's not a drug of third, fourth choice also. Uh, Coming to your this thing of what happens when the patient starts with a lower blood pressure. So this thing is that it is very easy to say, okay, in that situation start Vericiguat, but of course not many people can afford Vericiguat. So one of the this thing is that start with a very small dose. Uh, as we sometimes practice, we start with doses which are not were not used in the trial. So sometimes you have to use low dose. That means 25 milligram twice a day if you can. See, starting nothing, I mean, starting 25 BD is better than starting nothing. So as the patient tolerates and you keep monitoring, there are many patients where you start, stop, and that will go on. But that's how you will have to manage if you want to give ARNI. DAPA is usually very safe. It does not cause hypertension commonly.
Absolutely. So, Dr. Karde, I think the point was well being taken care of, because vericiguate is something that in case of worsening heart, especially in low cardiac output situation, when you give in due course of time, you might see that the hemodynamic is going to improve. And that is where I think, as sir has suggested, that you start with 25 milligram, remove all vasodilators like nitrates and high dose of diuretic, provided you do not have any hypervolemia. And then I'm very sure that the patient is going to tolerate those drugs. Try to achieve the maximum possible tolerable dose of all these four pillars, especially when we are giving RNI with SGLT2 inhibitor. You might see some sort of diuretic action as well. So you might have to reduce the dose of diuretic, and that is where I think the hemodynamic will improve and patient is going to tolerate the overall scenario. And for all heart failure patient with low cardiac output, I think the systolic blood pressure, the cutoff would be 95 millimeter of mercury systolic, and that is where I think the EGFR will also not getting so much affected. But one thing is, as sir has told, that one thing is very sure, that you should keep the patient under a strong follow-up for first 2 weeks after starting this therapy, so that you can always watch the patient carefully and then titrate the dose accordingly.
Yeah, just before I leave, one of the adjective is symptomatic hypertension. So if patient blood pressure is slightly low but is not symptomatic, you can
Correct.
continue with that dose.
Absolutely. So thank you, sir. Thank you so much for the inputs.
Sorry, I have to leave.
No problem, sir. No
Yeah.
problem.
Thank you.
So thank you, sir.
Thank you,
So
sir.
with that, I would like to switch over to Dr. Kamal Bhai. Dr. Kamal Sharma is going to speak about the lipidology, and from basics to rarity, I'm sure that he is going to touch upon certain novel emerging LDL receptor, LDL lowering agents as well. So over to Kamal Bhai.
Yeah, hi, good evening, Dr. Jay, Dr. Sapan, and our panelists. Can I have the slides? Thank you very much. So I'm going to take you through what is the best of the CSI. These were the talks that were held at the CSI, and they've talked about the basics and beyond. Can I have the next slide? So I'll take you through the best of the sessions that were there at the CSI. I presented one of our own paper, which was the consensus document about the use of nicorandil. Of course, that's not part of the lipids, but that's how I can say I had a glimpse into what was happening on at least that day of meeting. So next slide, please. So I'm taking you through the basics. We all know that there is a preponderance of atherogenic small dense LDL amongst Indian. Furthermore, we know that ApoB are elevated, and this is a unique atherogenic dyslipidemia frequently seen in South Asians, which is basically high TG, low HDL, intermediate LDL, elevated lipolittle A. Often the tetrad index, as we call, is elevated, and the ApoB is being elevated, representing, apart from the TG-HDL ratio, representing the atherogenic small dense LDL. For the same amount of LDL compared to Caucasians, we will have more heterogeneity because the same value is actually more dense and hence actually packages more of LDL particles for the same millimilligram percent that you measure for a Caucasian compared to Indians. We know this from INAS's data. We know this from racial studies that have looked into similar lipid profile between the Caucasians or the Westerners versus Indians who migrated to West, and they continue to have twice the CV event rates as compared to them. Next slide. So apart from that, of course, we have other issue, which is diabetes. You have a typical Indian diabetic patient. The prevalence of atherogenic diabetic dyslipidemia, as we call, ranges from 34%, and 73% of women have A1Cs more than 8. So most of our diabetic population is not only badly controlled, but also is dealing in 1/3 of them with a high diabetic dyslipidemia. 89.2, practically you can say every newly detected diabetic demonstrate a very bad dyslipidemia, leading to a ticking chemical time bomb, and you have a cocktail of atherogenic diabetic dyslipidemia. Next slide. So when you're looking at these aspects, you also need to look fasting versus non-fasting. A lot of times you have evening OPD, in the morning you're just operating, and then the patient walks in and you want to do a lipid profile. Can you do it? And you cannot. You can do it. Now, a lot of guidelines are telling it's good to do a lipid rather than not do it and defer it in the name of morning fasting, and patient never comes back. The advantage of fasting is it's a gold standard. highly sensitive to detect triglycerides, insulin resistance, preferable in certain high-risk patients for those who have high TG levels for exact cause, and non-fasting when your TG is more than 440, and it should be considered 2 to 4 weeks when non-fasting TG is more than 200 milligram per deciliter. Non-fasting, however, you can use for all lipid components, both heterogenic of hepatic descent and those from the intestine. It's used primarily in patients with diabetes because of increased risk of hypoglycemia for fasting. LDL can be precisely assessed using this technique. LDL is not requiring fasting sample. You need a fasting sample for TG, and this reduces patient burden of barrier of pricks, one in the morning, one in the evening. It increases patients' convenience, compliance, and of course, decreases strain on lab facilities, which has to run to thousands of lipid fasting samples in the morning. Next slide. So, yoga was another thing that was looked into. Yoga can mitigate hyperlipidemia. So, there were papers to talk about and highlight the same. Next slide. And this was the one which talked about how medical nutrition and therapy can be actually compounded with the diet being an integrated part of managing and mitigating this lipidemia. We know that the carbohydrates, which continue to have 50 to 60% of calorie intake, we need to limit use of rice, which is a big problem, especially down south. And practically in every home, there is always a bowl of rice, apart from chapati, sabji, and dal. So fiber content needs to go up from 25 to 40 grams, and fats, which is 30% of total calorie, needs to have less than 7% ideally, or at least less than 10% of saturated fat. You need to avoid that, and also hydrogenated vegetable oils. 15% of total calorie intake should come for proteins. It's very low in Indian setup patients, almost amounting only to 8%. And it need to consider age, the age of mine, or what we and Jay are now in. We will start metabolizing our muscles into energy, and we lose our muscle mass. So this is the time when we probably will require a lot of carbs and fats being replaced by protein, and this needs to be limited to high good genomic index protein, and it should, if in a non-vegetarian, should include red meat over other source of protein. Next slide. The statins continue to be pillar with genetic cause of dyslipidemia, both for primary and secondary prevention. High-risk individuals with diabetes more than 40 years and primary risk prevention is generally accepted to offer benefit of statin irrespective of their lipid profile. So once you know a patient who's more than 40 years of age and is being diabetic, blindly starting a statin, you are almost always right. Next slide. Again, the recent ADA recommendations are in concurrence with the AHA. For primary prevention, moderate intensity in lifestyle is advocated for patients with diabetes, even without any cardiovascular disorder, ASCVD between 40 to 75, and in Indians, you can extend it beyond 75 or maybe prepone it by a couple of years in the lipid profile associated disorders. Next slide. So which one, when to give, and what dose? Next slide. So there were some take homes from that with regards to, next slide, which looked into, next slide, Nirav. Yep. So there was a multicentric open label parallel group study by Lee et al., which compared Rosua versus ezetimibe as an add-on, which found out not only that the lipids do improve, but ApoB to ApoA ratio, which is a bigger and a better predictor, also improves significantly with a p-value of 0.03. So we now know ezetimibe with rosuvastatin or atorvastatin improves not only the classical lipid profile, but even the novel markers as well. Next slide. There was another study published about bempedoic acid, which is ATP citrate lyase inhibitor, first-in-class oral drug, which is effective option for statin intolerant patients. And this is one of the trials from the clear outcomes that has shown that it can be effective in preventing events as well. Next slide. So the other therapy, as Dr. Jay was trying to elucidate, was the PCSK9 inhibitor, which is basically human monoclonal antibody targeting the proprotein convertase subtilisin connexin type 9, which has been efficiently demonstrating a reduction of LDL by almost 70% in diverse high-risk subgroup patients, minimum 755 to as high as 72%. Next slide. And because of this benefit, They have been now touted with inclisiranol now on the horizon, breaking through, now being released already at CSI. One of the highlight at CSI was inclisiran being launched in India. And beyond that, now it's been touted as a lipid vaccine. You can give it once in 6 months after the initial 3 loading doses, and then it's like 2 shots a year, and you get good lipid control. Other subgroup which is also looking into in the statin intolerant patient, especially in diabetic dyslipidemia, are fibrates. We know from DIAS trial, which is a small study, which looked at significant reduction in TG with fenofibrate in type 2 diabetes. Next slide. Also, another therapy that's emerging on the horizon is the saroglitazar. It's been there for a while now, almost a decade. It's a dual PPAR alpha gamma activator, and hence it's not only improving lipids, but also in form of TG, but also improving HbA1c with a weak anti-diabetic action. Next slide. In diabetic patients, in special population, you need to evaluate and consider these patients differently. Type 1 diabetes, pediatric and geriatrics, and hepatic and renal impairment. Next slide. And in these subgroup of patients, you need to choose and define therapies which are specific for these conditions. For example, triglyceridemia in a type 1 would typically be reflector of inadequately controlled glucose levels. So much so that also may be the case with type 2. And in elderly and hepatic and renal impairment, I think it's pretty open that you need to be choosing nephro-friendly and hepato-friendly drugs, which can be of benefit in terms of preventing not only CV outcomes, but also nephrological and cardiovascular outcomes. Thank you. Thank you. Over to Jim.
Thank you, Kamal bhai. It was fantastic, very lucid, and very, uh, mm, you know, he has touched upon almost all the points regarding the novel therapies in lipids, and he has specifically touched upon the role of lipid, especially LDL lowering agents. So with that, if you can invite certain questions, let me start with Dr. Sandarbh or maybe Dr. Karthik, if they are there. Do you have any questions or query, Sandarbh? I think anyway. Let me start with one. Kamal bhai, what is your take on the eicosapentail ether? Like,
Yes,
especially when
again,
we are
it's
talking
been
about
another therapy that has
hyper-TG.
now come very strongly. EPA is another important therapy which has looked into diabetic dyslipidemia again. Also in residual TG risk in patients already on high dose statins. In Reduce It trial, we have looked into the subgroup of patients with TG levels being still high and LDL already achieved to below 70. EPA, when added, was effective in terms of reducing the event rates on top of these statins that the patients were taking. So it's more of an add-on therapy now rather than just a therapy for triglyceridemia. So I think we all know now that the residual risk persists irrespective of the LDL levels that you achieve, even to the as low as levels as
Absolutely.
55, especially in the reduced subgroup. Also, when you were giving these therapies, you were reducing event rates in terms of especially driven primarily by reduction in strokes. So strokes are very important CV events that are prevented by icosapentaen ether, but IPE is going to be a new cornerstone of therapy, and we again, it's not just omega 3 and omega 6; it's a different salt. We should not confuse it for omega 3, omega 6. IPA is a different salt than compared to what we talk of omega 3, omega 6.
Absolutely, and Reduce IT has already given us a good, favorable data regarding the same, and that is the reason I think the time must have come that we should change from fenofibrate to a newer therapy, which is probably clinically event-oriented, and that is how I think we can change or translate our practice on the basis of these supportive evidences. So, with that, Dr. Karthik, you were supposed to tell something.
Yes, I was just asking, like there are, we say for secondary prevention, lower is the better for like LDL cholesterol level. So is there any certain value for primary prevention as well? Like we say in diabetes, more than 40 years, we start the statins. Are there any like target
Talk
or
to
is it the same across time?
Yeah, good question. I think there's a lot of overstress on secondary. We should also be looking at primary. But we must remember that the net number to treat in primary prevention is so huge that adding statins to all may not be a great strategy. Even if you will look at the FCAPS or TechCAPS data, the number of patients that you need to treat to prevent a combined endpoint of EV introduction is going to be huge in 500s. While the net number to treat in secondary prevention like 4S or for that matter A to Z or acute coronary syndrome kind of
TNT.
setup or TNT or care, the net number would be like in 50. So that's the 10 times the number you need to treat. That's why people don't talk about it. But again, the number for primary prevention, especially in patients with FHF, familial hypercholesterolemia, needs to be brought down very drastically. And then there was a paper which looked at the x-axis and y-axis, where they pull out all the trials on the map and then try to take that to zero for event reduction. For primary prevention, it surprisingly also came below 100. So primary prevention numbers would be around 69 and secondary prevention would be around 38 if you were to count zero event rates by extrapolating these trials plotted with the event rate and LDL level on X and Y axis and drag that line, that would come like a straight line and drag that down to zero event rate, it would come to those numbers. So yes, I mean, you need to keep it below. I think the numbers are changing. 160 has gone to 130, 130 has come to 100. We are again looking at those event rates. So high risk patients, you need to define first the event rates. And again, now people are talking about cumulative values of LDL over a period of number of years. You multiply in that the threshold whenever you cross that of 5,000, as they say, you would end up getting that event rate. So probably with a mean of 100, 50 is the cutoff that you'll get that multiplicative value. So if you maintained for 50 years 100 LDL, 5,000 will come at 50 years. That's when first CV would likely occur. But if you were to maintain, say, LDL of 300, it'll come at 17. That's what you see in FHF. So it's a cumulative event rate, and I think the role of averages doesn't hold true. You need to keep the lower the value, the better it is. And as I often say in a lot of my conferences and talks, that the concept of average being normal is not true. We all have evolved from monkeys and chimpanzees and orangutans, and if you look at their lipids, their LDLs are in 30s and 40s. If you look at the Aborigines in the Australia or the Adivasis or Neanderthals or the population, tribal population of Nicobar Islands, their mean LDLs are still in 50s. I think the mean values of what we have started consuming, the milk of the cow and the buffaloes and the goats and the camels, has probably led us to develop false values of LDL, which is true not representative of what we synthesize inherently from our liver or what we are supposed to be dealing with. And this has actually led to a rise of human race's mean LDL values, which have now been adopted as two standard deviation from the dumbbell-shaped inverted curve and defined as normal. So the normality itself is a challenging definition, but for conceptually challenging the whole thing, I feel that the values would go to 90s and below. And as I said in this paper, which was fantastically looking at the event rates and the LDL values on X and Y axis and plotting all the trials, all the possible trials that if you go through, you will get the value, as I said, of 69 for primary and 39 or so for secondary.
Okay, excellent. Kamaldeep, just for the sake of giving some message to the physicians, which type of calculator they should use for the stratification of lipids in diabetic individual, and what is your take on following the guidelines? Like we have a LAI 1 and 2. So do you give a due importance to that guideline because they are little more comprehensive and they can be utilized for the
The LI
Indian
guidelines
discipline
are
patients?
better as in terms of they're looking into Indian perspective. But again, I strongly feel that the LI guidelines would be much better, and Lipid Association of India is not at fault at all. But we guys have not generated enough data sets from our
Correct.
population to actually substantiate that. They unfortunately have to rely on small anecdotal primary prevention epidemiological data sets rather than therapeutic interventions. A lot of it also is responsibilities of investigators like us who don't do such clinical trials. Also, the industry that does not support such clinical trials. If I was to decide and quit my interventional practice and say that I'll become an investigator, I'll be out of business. I may have to pay my loans by asking Jay to pay me. So I think it's not a lucrative job to be an investigator if there is no enough funding for the same.
Funding.
And that's the reason that we don't get enough data. I mean, imagine if we were to be paid more than doing an intervention. I'm sure I and Jay will
Absolutely.
migrate and become researchers. So
From tomorrow
unfortunately,
onwards.
that's the reason that we don't get that kind of data sets, and Lipid Association has to talk about data is borrowed and then there is a consensus statement. So the strength of evidence with lie is not so great, but they are more touched upon into the current situation in market and the current Indian perspective. Need substantial support from industry, investigators, researchers, funders, community to be substantiated and be robust and strong. Till then, of course, I continue to rely upon Curious 3 as well as lie to
Seriously.
some extent, but I do individualize and try to calculate risk for each of my patient, because patient A is not equal to patient B. You may have, if you go through Curious 3, what I like is that if you have migraine, you're at risk of stroke. If you have history of rheumatoid arthritis, you also have strict risk of getting a CV event. Those are
Absolutely.
considered, and it's more comprehensive. It considers a lot of other aspects. And that's the reason I'm more happy using Curious 3. Also, one of my residence thesis was comparing all these scores in our Indian patients who are undergoing coronary angiogram, more than 1,500 patients with coronary artery disease and the scores. Again, we found out Curious 3 to be better. This paper is already submitted, and I think it's in the peer review, will be published soon. We have compared ASCVD, FRS, Curious 3 with the other risk scores, and Curious 3 was found to be having a better ROC as compared to the others. So I think I'll go by Curious 3 as of now for being able to. But again, even in that data sets, we found out that you end up missing out on a substantial, nearly 30% of patients who had a bad CVD, but none of these score could predict it. That's the problem why you need Indian data sets and Indian population risk as estimators. You cannot rely on ASCVD, you cannot rely on QRisk.
Absolutely. True. So with that, it was fantastic, interesting talk and inputs from Kamal Bhai. Sapan Bhai, I could not see any questions in the chat box. If you can see any questions from the audience or any, maybe Dr. Karthik, if you have any other queries.
It's a wonderful talk.
Uh,
I
do we
think,
have Dr.
sir,
Sandar?
Dr. Sandharv is not there, and Dr. Dinesh Raj has stuck up in some emergency, so he could also not join. So, from audience, if any questions are there, let us invite them in chat box, and if not, then let us conclude.
Sure.
I think there is one question. Sir, can you read it?
I'm sorry, I'm not able
Yeah,
to
I
see it
can. So
because
it says 40-year-old diabetic,
Yes.
increased TG, started metformin. Should I start statins or wait? That's a question from Dr. Ravindra. There is a question of on by Dr. Jitendra Patel about drug of choice of paroxysmal AF with heart failure. So I'll take these two first. There is third one as well. So first one, 40-year-old diabetic. Oh, there are more. A lot of popping up now. So 40-year-old diabetic, increased TG. I think you should control your A1C, FBS, PPBS, but surely start an A1C. There's no, I mean, irrespective of A1C, with the anti-diabetic regimens, should always be started on statins. I strongly feel that, as we just saw. If you were to calculate ASCVD for a 40-year-old diabetic without any other risk factors, for the LDL values, you will surely calculate your risk to be more than 7.5. In that case, you'll have to be on statin. So I would, but then TG is something that would be reflected by uncontrolled hyperglycemia. Always in an uncontrolled TG, look at thyroid, look at nephrotic syndrome, rule out drugs causing hypertriglyceridemia, try to bring the sugar under control, and then first target the LDL with
LDL.
statins. Still, if it's more than 200, like in the as we were discussing about reduce it, and where the cutoff was 150, in that patients you can think of the novel therapies for TG lowering, especially for the introduction. Drug of choice of paroxysmal AF in heart failure. See, most of the trials with AF have looked into the drug of choice being amiodarone, but it's a very toxic drug. We need to be putting that under check and should not be given for a long duration. In view of a heart failure, that's the choice. But if you don't have a structurally abnormality, you have a normal heart, then the paroxysmal AFib will very well be controlled with beta blockers alone, and if required, a flecainamide or mexiletine, etc., as a maintenance or prophylactic dose. Another question is by Dr. Ankur Raval, long-term use of high-dose statins and incidence of new onset of diabetes, concerns and solution. It's a good question. People talk about NOD. So you must remember that 100 patients started over 5 years duration, 7 will develop new onset diabetes. Most of these are pre-diabetics. These would proceed by 7 years. I mean, you were to develop anyway diabetes for 7 years down the line. You develop it 5 or 7 years earlier in only 7 patients. But by giving 100 patients, diabetic patients this drug, or in a pre-diabetic subgroup, you prevent 30 events. So you have a net benefit of 23. I think these patients should not be worriedly stopped from taking statins. This concern was primarily by rosuvastatin. If you're so concerned, take atorvastatin. It shouldn't be a problem. Always take it. Dyslipidemia is another question Dr. Ankur has asked. In hypothyroidism, yes, you would get elevated TG and also LDL elevation, but you can actually manage both simultaneously. Start with thyroid replacement therapy, low dose of statin, check on a lipid profile once the TSH is back to normal. And if it still persists, you can continue with lipid management accordingly. Best study book for treatment guidelines, therapeutics is Ravindra's question. I think there is no book per se about treatments and guidelines. You'll have to keep sticking, because I think I really find the ESC guidelines that have been published in 2023. I'm sure Sapan or somebody would help you out with the new ESC guidelines about management strategies. They've built up a book. Last year's CSI book was really good. I found that one good because it included a lot of guidelines and updated chapter. Not that I wrote a chapter in that edition, but that was one, maybe because I wrote a chapter, so I went through the chapters. So that was also good. I'm not yet to go through the current book of this current CSI, but I think you'll have to stick to, for guidelines, subscribe to acc.org, which is American College of Cardiology, or esc.org, which is looking at the European guidelines. I usually stick to that. Intervention, if you're keen, you can look at the SKY guidelines, which are very much in line of the ACC AHA task force. So I think that's my suggestion for the guidelines, because they keep changing. You cannot have a book. I think that's it. I don't see any more
That's
questions.
it, I
Any other
think.
questions
Yeah.
in the chat box?
Over to
Sapan bhai.
Sapan bhai.
Yes, sir. So shall we conclude now?
Yes.
Thank you, Dr. Jay Shah. I extend my sincere gratitude to our esteemed speakers, Dr. Atul Abhyankar and Dr. Kamal Sharma, for sharing their valuable. Sorry.
No, go ahead.
Okay. For sharing for their valuable insights during this insightful webinar. Special thanks to all our panel members, Dr. Dinesh Raj. Unfortunately, he could not join us, but still Dr. Sandar Patel and Dr. Karthik Bosle for sparing their valuable time. Your active participation and thoughtful questions have made this webinar much impactful. Thank you very much for all the participants, and our special and heartfelt special thanks to our dedicated coordinator, Dr. Jay Shah. Thank you once again, everybody. Have a sound sleep and good night.
Thank
Good
you.
night, everyone. Take care. Bye bye.
Good night. Bye bye.
Bye bye.